Well, good morning, everyone, and welcome to our Grand Rounds, and this one would be a very special Grand Rounds. It is the 26th annual Bill Winters Lectureship, and glad to have Dr. Winters with us here today. I have a few announcements before we go through some of the presentations, and February actually is going to be an amazing month for education. We have the Houston Heart Failure Summit, February 8, Heart of a Woman program, February 16, and a multimodality 9th annual cardiovascular imaging for the clinician, and that will be February 22 to 24. Also, as a reminder, these Grand Rounds are live streamed on Facebook and they're archived on YouTube channel. So you can join more than 8,000 followers on YouTube with us for our Grand Rounds. Well, this lectureship is very dear to us because Dr. Winters is dear to all this family here and the cardiology community, I would say not only in Houston but in Texas, as he was one of the fathers of cardiology here in Texas, brought after a phone call from late Dr. Chapman to come down and visit, and he stayed. And actually, he did so many things for the cardiology and cardiology community. He was the first to have an echocardiography laboratory at that time here in Texas, was president of the Heart Association chapter here, president of the American College of Cardiology, master of the American College of Cardiology, as well as the American College of Physicians, and not only a statesman and a mentor to so many cardiologists, including myself and so many others, but also an amazing writer. And I would encourage you to take a look at Houston Hearts, among many other writings that he's done. And he was the initial founding editor of our DeBakey Heart Journal. Well, this lectureship actually is the longest standing lectureship here at Houston Methodist, and it brings about among the most prominent investigators, as well prominent collaborators and inventors in the field of cardiovascular medicine, and this year is no exception. We have Dr. Robert Harrington, a dear friend over the years and dear friend of the community here, of many others. He's chair of medicine at Stanford University, and he is the Arthur Blumenfield Professor of Medicine at Stanford. Bob did his training initially at Tufts, then at the University of Massachusetts in Worcester, then cardiology at Duke. And I know he cares a lot about Duke, including their basketball team. And this is really where he made his impact on cardiovascular medicine, with more than 500 publications in the field of acute coronary syndrome, thrombosis, and you name it, clinical trials. He was even there before DCRI, which he chaired later on. And I think his contributions have been phenomenal nationally and internationally. And it really is amazing of so many contributions that Bob has did over the years. Senior editor for Hearst, the Heart, and as one of our faculty here he served 2 terms on the cardiorenal advisory committee for the FDA. Involved in so many organizations, and I got actually to meet him and know him well at the American College of Cardiology when I served as president. He was on the board of trustees. And I can tell you that it is not the academic portion that is even the most stellar. It's his personal attributes and his contributions with wisdom and a lot of experience in the field, not only of cardiovascular medicine, but also in life education and research in general. And I think we tapped on his wisdom, and I'm sure this is what drew the American Heart Association to tap on his expertise. He's on the board of trustees and actually president-elect, and will take the reins of the American Heart Association presidency this next July. So Bob, it's really a pleasure having you here, and we look forward to your, I wouldn't say intriguing, but certainly very stimulating area that you're gonna address today, because not too many people have the breadth and the width of addressing education and research in a world that is changing around us. It's great to have you.
Thank you, Dr. Zoghbi. Thank you, Dr. Winters, and certainly to a lot of friends and colleagues. I really very much appreciate being here and am honored, humbled to look at the list of people who have given the Winters Lecture, to be counted among them. Most of my relationships are regarding my research. What I'm going to try to do is to create for you a picture of this notion of how we think about digital health, how we think about mobile health, how we think about big data in the world of our cardiovascular medicine now. And I will give examples throughout the presentation of a lot of the work that our group is currently working on. By no means is that to suggest that this is the only issues going on, but it's the areas and the examples that I'm most familiar with, and so we'll focus on that. We'll talk first about some of the big societal issues in cardiovascular medicine, and I put cardiovascular in parentheses because I'm very aware of the fact that while I'm going to talk from the perspective of a cardiologist, many of the things I'll talk about are germane to areas outside of cardiovascular medicine. And I'm going to try to give you some examples that I think can really change care from the research realm in the course of the next, I'll call it 3 to 5 years. I think I've said the next 5+ years. Every single thing I'm going to talk about relies upon the accumulation, the aggregation, and then ultimately the analysis of vast amounts of data. And I'll make the case that we're really at a precipice for major change because of that particular fact in medicine generally. And I'm going to concentrate my remarks around five categories. We'll talk about this whole notion of big data, what it is, what it means, how we might think about it. I've spent much of my career thinking about ischemic heart disease clinical trials, and we're going to talk about how best, and I think in a much more efficient way, to align clinical trials with clinical care. We'll talk about this notion of learning healthcare, and then a really key component is how do we engage our patients and then the broader community of consumers in health and wellness and disease management, because we now have new tools available. And then I'll finish with some thoughts on new skills for healthcare learners to acquire. So a lot of what we're going to talk about is the backdrop is really summarized here. CV disease is the globe's leading cause of death and disability, and I'll show you that data, but I'll also show you some recent data which shows some both interesting and perhaps disturbing changes in the United States. We'll talk about this notion of team-based care, about care being driven and measured by quality, this notion that population-based care and personalized medicine are not dichotomous, but in fact are mutually interdependent. We'll note patient-centeredness, technology, big data as we've talked about, and learning opportunities. And some of the words and some of the themes that you'll hear me repeatedly come back to are listed here. Things like accountability, collaboration, innovation, technology. All of these will be discussed. But I'll also wrap around this as I go through this notion of humanity. I'm privileged at Stanford to work with the physician author Abraham Verghese, whose office is right next to mine. And he talks a lot, as many of you know who follow his writings, about this notion of humanity in medicine. And I'll return to that throughout the presentation because it's really going to require that personal interface in the care of fellow human beings enabled by technology, not the other way around. So you all know that cardiovascular disease is the leading cause of death around the globe. It's actually the leading cause of disability around the globe as well. And the predominant form of that death is now ischemic heart disease. Rising up from number 4 in the world's leading causes of death and disability over the course of the last 20 years. As we export a lot of bad Western habits to the rest of the world, we see a rise in ischemic heart disease. And I think that that's an important concept for us to think about. There was a paper that came out of Stanford from the department a couple of months ago led by Latha Palanipian, who is an internist epidemiologist working in the department. And this is really looking at the country's causes of death, getting down to the zip code level around the country. And what you note over the course of about a 10, 12-year period is that we've had a shift in cause of death from heart disease to cancer. And by 2023, cancer will replace heart disease as the overall leading cause of death in the United States. But it's going to be very geographically dependent. And if you look at red as heart disease deaths and the blue as cancer deaths, you can see a transition as you move from 2003 to 2015. Some have also argued that this follows the electoral maps of red states and blue states. But what it points out is that almost all of the change in cardiovascular disease can be traced back to public health measures, lifestyle, poor socioeconomic status, and the social determinants of health and wellness. And we're going to return to this theme, but I think this actually offers opportunity for the cardiology community to think about the broader issues of how we can continue to reduce cardiovascular disease, not just in the acute care setting where many of us have spent the bulk of our careers, but really thinking more broadly from a policy perspective and a population health perspective about how we can really move the needle, particularly on ischemic heart disease. Now, I added this slide after I had dinner with Dr. Winters last night, and as we talked about some of the folks that he knew at Duke over the years, and one of them who is one of my personal medical heroes is Dr. Eugene Stead, who was the longtime chair of medicine at Duke, and really had two fundamental contributions to medicine, one of which is he is the founder of the physician assistant profession, and the second is that he was the founder of the Duke Data Bank for Cardiovascular Diseases, which ultimately morphed into the Duke Clinical Research Institute, which was my former research group at Duke. And Dr. Stead, my friend Rob Califf likes to say that every time he has a good idea or what he thinks is a good idea and he begins to research it, he realizes that Dr. Stead thought of it 40 or 50 years ago. And in fact, when you go back and you read Dr. Stead's writings, he was advocating for the aggregation of information to be available at the point of care and thinking about patient using computer technology in the 60s, which is really an extraordinary notion. And in 1972, he delivered a keynote address at the American College of Physicians called The Way of the Future that was subsequently published as a paper. And in that, he lays out the constructs of what I would call the modern registry or the modern accumulation of data using computer systems. The challenge that Dr. Stead had is that his ideas were just way ahead of the technology. And we'll talk about how we might be able to address that today. Well, let's first address this notion of big data. This has been a topic, the phrase is used almost ubiquitously in both the lay press as well as in the scientific literature. And if you trace things through the lay literature, through things like Time Magazine or The Economist, we've seen over the course of the last 10 years or so at least two major covers on The Economist which got great public pickup. One was called The Data Deluge, and the most recent one making the case that oil is no longer the world's most valuable resource. In fact, data is the world's most valuable resource. And so let's talk about that. And if you want to understand sort of the beginnings of this concept of what has been referred to as datafication, or the notion that you can turn virtually anything, images, ideas, mathematical equations, into data, this book is a terrific review called Big Data, A Revolution. And this really sets the construct, not just in medical care. The whole data revolution begins as people began to map the shipping channels of the globe several hundred years ago. And the accumulation of weather data and the accumulation of tide data and current data was the first example of how people used accumulated, aggregated information to make major societal decisions. So this is a book I would highly recommend. And there's this notion then in medical care that there is a lot of data that we're leaving untapped or unused as we think about caring both for populations and for individual patients. And this viewpoint in JAMA a couple of years ago by Griffin Weber, an informatician physician at Harvard, called the Tapestry of Biomedical Data, where he really makes the case that the electronic health record only contains very little about what we know about the health of an individual and consequently the health of a population. And the challenge for the coming years is how do you take very disparate forms of data, data that's both structured and unstructured, and begin to bring that together in a way that allows you to make inference about things about the population, things about that individual regarding their status of health. And so again, a great visual of a tapestry of how we pull together all of this information, or how we pull together all this data to make it useful information. And certainly our colleagues in industry, this has not been lost on them. As people begin to buy data for extraordinary prices, IBM bought Truven for $2.6 billion. Flatiron, which is really concentrating on data in the cancer space, was acquired by Roche for several $billion as well. These are really extraordinary times where data is felt to be the most important commodity. But it also raises questions like this. Do we as a society trust the technology companies like Google and Facebook to control this data? If this is such a valuable resource, what is it that there should be regulated in this space? What is it that should be controlled through policy in this space? I think that those are questions that society is really going to grapple with over the course of the next few years. So let's move now to the topic of thinking about reclassifying health and wellness, because we now have vast amounts of data to really allow us this notion of precision health or precision medicine. We have a new president at Stanford after many years under the leadership of John Hennessy, who was an electrical engineer. We now have a new president, Mark Tessier-Levine, who comes from the area of biomedicine. Mark is a neuroscientist who spent time at UCSF, time at Stanford, time at Genentech, and then most recently, before coming to Stanford, as president of Rockefeller University. And in his inaugural address to the Stanford community, he referred to the 21st century as the century of biomedicine. And he gives a number of examples where we have unparalleled knowledge at our fingertips about science, about medicine, but he ends with the fact that what's going to make that knowledge useful is the rapid advances in cloud computing, something that Dr. Stead could have only dreamed about. But really it's cloud computing and advanced analytical computational methods that have really changed the game over the course of the last 3 or 4 years, as we think not just about vast storages of data, but actually how to bring together very disparate types of data in that tapestry, if you will, and how we bring together that disparate sources of data and begin to think about it in ways where patterns that we might not otherwise have been able to imagine can truly emerge. Well, certainly for those of you who are basic scientists, and it's been nice to see my friend and former colleague John Cook really thriving here, those of you in the basic science realm are really starting to think not so much about your own experiments, but how your experiments also interface with other experiments from other laboratories. And this whole notion of network biology or systems biology is really taking hold in things like drug discovery, really helping us think about how do we bring together information on the proteome, the genome, et cetera, to really make better sense of diseases. Most recently, the American Heart Association has just embarked upon a collaborative relationship with the Lawrence Livermore Supercomputing Lab to think about how can we change the pace of drug discovery using supercomputers, systems biology, and advanced computational methods such as artificial intelligence. And at Stanford, we've noted in our work on precision health that what we're trying to do is predict, prevent, cure, and do it precisely. And what you'll notice that at the center of the themes that we talk about on our campus about precision health are the data and the biohub. How do we bring together information on individual samples, et cetera, but do it in a data infrastructure that allows us to bring together all these very different pieces of information? One of the examples that I want to give you is a project that we're engaged with our colleagues at Verily, formerly known as Google Life Science, and our colleagues at Duke, is a project called Project Baseline. And the Google group likes to say that they've mapped the world, now let's map human health. And the notion here is that there is a transition between health to disease that in many ways is not well defined, in many ways is not predictable, in many ways is not understood. And in part of that is because the basic construct of the way that we care for people is episodically. But it's been estimated that people spend on average, less than 1% of their time actually in the formal healthcare system. And so there's a lot of information that's being accrued continuously that might help us understand those transitions from health to disease and from disease to recurrent disease that could be useful. And so we've embarked upon a project with our colleagues, again, at Verily and at Duke, to enroll 10,000 subjects, 5,000 in North Carolina, 5,000 in Northern California, who have either cancer, one of the 4 common tumors, solid organ tumors, or cardiovascular disease, ischemic heart disease, or in fact, neither of those nor any risk for those, to try to collect a variety of information in a way that's never been done before. This is thinking about phenotyping people and categorizing them through imaging, blood testing, and continuous monitors in a way that's not been done before, and I'll describe that. So we're interested in identifying new biomarkers, developing new technologies, creating digital platform to connect all of this, and doing some of it in a continuous way. So patients, subjects, some are patients, some are subjects with no disease, are enrolled. They come in for a 16-hour set of assessments over 2 days, and then they're followed up annually, but they're also followed up continuously through a series of monitors that are embedded into their homes where information is continually accrued. And what are we interested in collecting on them? We're getting their typical EMR data and having access to their EMR, getting clinical data, imaging data, physiologic data, environmental data, cognitive testing, collecting information that allow us insight into the social determinants of health, et cetera. And for those of you who wonder, well, what's Verily's interest in this? Each subject at each visit is contributing 6 terabytes worth of data. And again, none of this would be possible without advanced cloud computing and without advanced computational methods. And you can see that the data is coming from really different sources. And so part of the challenge is how do you bring that data together in a way that allows us to draw inference about things like health and disease. These are just some of the in-home embedded devices. There's actually sleep sensors to try to understand patterns of sleep and the relationship to health. There's study hubs, think of Alexa or Google Home devices to collect ambient background information, wearable sensors, et cetera. Yeah, if you live in Silicon Valley, you don't get creeped out by this, but if you live in Texas, you might get a little more creeped out by this. And we'll keep talking about this. So we're collecting a huge amount of information. Patients are giving us their information through a particular participant portal, and we'll be reporting out. We have the first 2,000 subjects enrolled, approximately 1,000 in each location, and we're reporting out the first series of observations later this year. We really think that this will give us a very different look of human health, to really think about how do we, number one, how do you accumulate that much data? Number two, how do you actually make some sense of all of that data? And how do you continue to collect data and in a longitudinal way? The study has been funded for at least the first 5 years. For those of you who will ask the other question, well, who's going to have access to the data? The intention is to make the data fully available to the community of scientists. So stay tuned on that as well. The American Heart Association is also very involved through the creation of something called the Institute for Precision Cardiovascular Medicine, and we've launched a variety of programs, some of which you know. One of which I just mentioned, the Center for Accelerated Drug Discovery, led by Joe Lascalzo in collaboration with the Lawrence Livermore Lab. Oh, thank you. In collaboration with the Lawrence Livermore Lab. My Research Legacy is a patient portal for patients to contribute their data. And the Precision Medicine platform is something that, again, is available for the community at large. We've brought together a number of large data sets from around the country where you can both contribute data but also use data. It's particularly, I think, a rich resource for young trainees and faculty who do need to get pilot data, for example, and that can be very much facilitated through our Precision Medicine platform. there's also a number of grants available through the Institute in collaboration with Amazon Web Services that provides both money and advanced cloud computing technologies for you to do the kind of analyses that are required today with multiple disparate sources of data. So if you think about that as some of the things going on in the precision health space, let's talk now about the area that I've spent much of my career in, which is the area of large cardiovascular trials. And I'm going to try to make the case that all of the technology that's available today allows us to simplify trials, to better align trials with research, research with clinical care, and hopefully do trials more efficiently. Certainly the advent of or the launching of the large cardiovascular megatrials, the GC trial was the first, the ISIS trials, the Gusto trial, where I first met Professor Kleinman many years ago, really signaled to us an important advance in cardiovascular medicine. And virtually no other area of medicine, now that I sit as a department chair, has really embraced this kind of research, of really doing very large-scale clinical trials to answer very, very common clinical questions, and recognizing that it takes that kind of scale to make the modest incremental steps that are usually what we make in medicine. But cardiology has certainly led the way. And Mike Lauer from the NHLBI has referred to the cardiovascular megatrial as disruptive technology. But unfortunately, this seems to be most of the trials that I've worked on of late. Randomized, double-blind, 20,000 patients, conducted over 10 years. Unfortunately, we've forgotten why. The trials go on for a long time. They're very difficult to do. Oftentimes, the field is moving on while the trial is being conducted. And so, why is that, and is that a problem? When Elliot Antman and I wrote a viewpoint on this a few years ago and made the case that we think that what happened was the original simplicity was lost, and it led to increasingly complex trial. And the consequence was to threaten the very existence of RCTs, given the operational complexities of the ensuing costs. It is not unusual for one of these large cardiovascular megatrials to cost in excess of $500 million to conduct. Even a large NHLBI trial with all the constraints of government funding can cost well in excess of $100 million to conduct. Begin to think about, are there other ways to take advantage of pre-existing data, for example, data that's in the EMR, data that's in registries, to do clinical trials. And a group of us came together to write about this and to talk about things like large pragmatic trials that use the EMR, clinical trials that use registries such as the ACC's NCDR. And like many things that you think are great ideas, oftentimes somebody beats you to it. And in this case, our friends in Sweden beat us to it, because the Swedes have a very advanced set of national registries where they capture all healthcare information on their population, which is about 10 million people from birth to death. And they are facilitated in their doing of that through a national identifier. And so they can track pharmacy records, hospitalization, procedures, adverse events, et cetera. And so they really, I think, set the tone a few years ago when they published the thrombus aspiration trial, where they enrolled over the course of 2 years in Sweden almost 70% of all the myocardial infarction patients in the entire country over 2 years. Talk about generalizability. And Mike Lauer wrote the editorial for this, where he asked, was this the new disruption in research? Being able to truly take advantage of embedded information. So then, can we do this in the United States? And as you know, PCORI was formed as the Patient-Centered Outcomes Research Institute was formed under an act of Congress as a quasi-government institution, meaning sitting outside a lot of the typical governmental structure, with the notion of how do we take advantage of all of this data around the country, particularly through the electronic health records. And then as they invested several $100 million into the creation of data networks around the country, what could we do with that? Well, the initial thought from PCORI was that it would be a rich source for the mining of observational data. And it turns out that it's also a rich source for the construct of randomized clinical trials. And so imagine if you could do a clinical trial rather than taking 20,000 patients over 10 years, but if you could pre-qualify hundreds of thousands of patients at only a very small number of sites. And if you could do this all in a very efficient way, including taking all of the information out of the electronic health record as opposed to collecting it in a case report form. And so we're actually doing this in a project funded through PCORI called Adaptable, where we will randomize 15,000 patients at only 30 centers over 24 months. And it's because this network has been created by PCORI called PCORNet that brings together researchers and patients, data, health systems. And the first large-scale trial funded by PCORI to do this is a trial called Adaptable. Now, Adaptable is answering that burning question that you've all wanted to know. Is it better to take 81 milligrams of aspirin if you have ischemic heart disease or 325 milligrams? Well, in fact, we don't know the answer to that. PCORI liked this question because they felt that it had broad public health implications. It was something that was not known. In fact, using the NCDR, a group has determined that roughly 45% of people who've had an acute coronary event go home on 81 milligrams of aspirin, 45% go home on 325 milligrams of aspirin, and 10% go home on all sorts of doses of aspirin. And when you look very carefully, can you determine why they go home on those? There's no rhyme or reason to it, at least that you can detect with reasonably robust statistical methods. It's not necessarily a function that the little old people go home on 81 and the stout middle-aged people go home on 325. It's not that simple. And so we thought that there was community equipoise. We're doing a large randomized trial, testing those two doses to try to understand it. We're using the electronic health records that have been collected through PCORI in something called the Common Data Model, and we've created what we've called the computable phenotype to identify patients within those electronic medical records to understand, do they have atherosclerotic disease, do they have some risk factor, and can we reach them? Well, we are doing just that. We're doing all the enrollment, all the follow-up through the electronic health record, with some assistance through our colleagues at the Duke Clinical Research Institute for follow-up so that we don't lose people. We're also embedding in it a variety of questions to try to understand the best methods for doing large-scale pragmatic trials within the electronic health record, including things like, after patients had a myocardial infarction, do you need to see them at 1 month, 3 months, 6 months? We're actually randomizing people for follow-up to see if we get a differential quality of data and whether or not there is differences in their clinical outcomes. I've rarely seen enrollment curves that look like you projected it, and in fact we will finish the trial later this spring with the last patient being enrolled in May, 15,000 subjects, following them, then locking the data and reporting the data out sometime in 2020. So we've actually demonstrated that first, from a methodologic perspective, you can do this. You can do large-scale randomized trials using electronic health records in the United States. We will know over the course of the next few months, can you do it in a way that you assure yourself high quality of data? And then later in 2020, we'll actually know the answer to the question. What about leveraging healthcare data, learning healthcare and leveraging data? Again, oftentimes the ideas come from the past. This is a paper that came out of the Duke Data Bank in the early 1990s by Rob Califf and Bob Rosati, where they make the comment that in the future, data banks will provide a reference laboratory for each patient with chronic disease. 1981. We're still far away from that, but we're now poised at a level that we can actually do that. They do note, though, and this gets back to that notion I said to you earlier about understanding the humanity of the whole thing, that proper interpretation and use of computerized data will depend as much on wise doctors as any other source of data in the past. This is actually the first records of the Duke Data Bank. They gave me this as a picture when a framed picture from my office when I left Duke. This was the log of the Duke CCU when Stead had the idea that you could take this data, then enter this into the computer and have it serve as the beginnings of a computerized database for all the people who went through the Duke CCU and then ultimately through the Duke Cath Lab. So this was the original Duke Data Bank. And this was the original use of the Duke Data Bank, which was creating something called the prognostogram, where people could take aggregated information on patients who had gone through the Duke system and try to understand using a variety of, in this case, this is relatively straightforward multivariate analyses, trying to understand what therapies might be best. In this case, was it bypass surgery or medical therapy for people with varying degrees of coronary disease? And this is felt to be a way that provide clinicians at the point of care information that could be shared with that patient so that informed decision-making about choices of therapy could take place. And you say, well, of course, we do that all the time. But this was in the early 1970s that we were beginning to do that. Well, now we can really do that. And a group of us put this paper in Health Affairs a few years ago, this notion of, can you use a green button for using aggregated patient data at the point of care? This came from a conversation where I asked the question of my two informatician friends, Chris Longhurst and Nigam Shah, why can't I just press a button in the EMR and get all these analyses done behind the scenes so that I can get great data like Stead said I would have at the point of care? So we wrote a paper about this, and we described the construct of how that might take place in the paper. And now, with funding from our healthcare system, along with the Department of Medicine, along with some grants, we've actually created the green button system within the Stanford system, where anybody throughout both the pediatric healthcare system and the adult healthcare system can ask for an informatics consult, where you can ask us a question, and it's typically been used for people who have a patient with an unusual presentation of something, or perhaps a rare disease that they've not seen. And we now have the ability to scan through tens of millions of records and utilizing some tools of artificial intelligence and machine learning, be able to provide back to the clinicians a series of observations similar to what we provided in the prognostigram back in the 70s. We've done a pilot of over 115 or so of these consults over the last 9 months, and we're just formally launching, supported by our healthcare system, the informatics consult service this year, utilizing the green button technologies. And in fact, if you go to greenbutton.stanford.edu, you'll be able to go to Dr. Shaw's lab and be able to see exactly how we're doing it. And if those of you who are in the audience who have responsibility for this stuff, we're looking for other institutions to collaborate with, because what we would like to see is a nationwide system of sharing of data, so that if you have patients that have something potentially unusual, we could scan all of the data to be able to think about what might be the best choices of therapy. So cloud computing, aggregating data, really important. But the other major step forward is advanced computation. And the thing that's getting all the buzz is artificial intelligence. It's also been poised as an artificial intelligence, the machine versus the MD. And I'm going to try to make the case that it's the MD with the machine that's really where the future is going to be. This is, again, not new ideas. 1966, there was a whole set of discussions in the radiology literature about computer-aided analysis of radiographic images. And in fact, if you follow Dr. Ludwig, I had the chance to go back and read a series of his papers. We're very forward-thinking in the 50s and 60s about how you might use computers to help the radiologists. Even in this paper, they lay out this notion of, couldn't we just sort the radiographs into bins? Even if it was, these are all the normal ones, you don't need to look at those. Here's all the others, look at these. This is 50 plus years ago. Eric Topol has an absolutely magnificent review on the topic, just came out 2 weeks ago in Nature Medicine, called High Performance Medicine, the Convergence of Human and Artificial Intelligence. And for those of you who want to sort of understand the basics of artificial intelligence, machine learning, deep neural networks, et cetera, this is a great paper to start. And there's a whole series of papers in this version of Nature Medicine that are worth doing. And one of the things that Dr. Topol makes the case for is that the world is changing rapidly. And what he lists here in these two tables are, number one, is just all the peer-reviewed publications that are starting to compare AI algorithms with physicians and who's winning. And then the second is the FDA is now in 2017, 2018, beginning to improve technologies that rely on artificial intelligence algorithms. And this has raised a whole lot of questions in regulatory circles about Well, what does that mean? I mean, when you have a pill, you know what it is. When you have a device, you know what it is. When you have an algorithm, the very nature of it is that it changes as more data becomes available. And how is that going to be regulated over time? And I think some of those issues still have to be worked out. But Eric gives you some great ideas about how you do take, for example, from a project like Baseline, all that data that's available, bring it together in what have been called stacks. And then through the use, again, this is not conventional statistics. How do you begin to understand how the various connections that you don't necessarily intuitively see and make some inference about patient health? And so there's a variety of things that people are looking at AI in healthcare for classification, for optimization. My colleague Mintu Tarakia says, maybe it's just going to help us with the mundane things that we don't want to do. And that would be a huge win. And I can already think about the clinicians, some of the things you're thinking about. What are the things I don't want to do? Stay tuned, and I'm going to show you some things. Another great paper in the same issue from Atul Butte, colleague at UCSF, is this call for not just learning healthcare, but deep learning healthcare. And Atul has made the proclamation that hospitals, health systems that are not utilizing their own data in this sort of way over the course of the next 5 years are really falling behind. And I've asked him the question, why is it going to be 5 years? I think the world's moving much faster than that, and we're going to be able to utilize data across healthcare systems to improve care. Let me give you some example. This is one of my favorite ones. There's a class that's taught at Stanford between computer science, Andrew Nying, and the Department of Medicine, Nigam Shah, who's an informatician. And in this class, they require the students, undergraduates and graduate students, to give 30 hours a week to work on projects. So a group of 4 Stanford undergraduates and 4 Stanford graduate students working for a month on a data set that had been publicly available through the NIH for over 10 years on a series of chest x-rays which had all been carefully annotated. They demonstrate that the algorithm, the AI algorithm, can actually do better than radiologists in the reading of the detection of abnormalities and the classification of abnormalities in chest x-rays. Interesting observation. They've now updated that with a publication just came out last week in PLOS that really talks about not just, in this case, diagnosing pneumonia, but really diagnosing the most common diseases of the chest and providing information back to radiology. We're moving into a new Stanford hospital, and yes, John, they're still building it, and in 2019. And in half of our ICU beds, we've arranged with our healthcare system to put in bedside computer vision to be able to look at workflow in the ICU, particularly by our nursing colleagues. Over the course of a shift in an ICU, our nursing colleagues make something like 600 individual movements in the care of a patient. And the question is, can they do that reproducibly? Well, probably not. But which ones really matter? And can we use bedside computer vision and the tools of artificial intelligence to provide feedback about the movements that might matter? And can we utilize that to improve things like patient safety? We're also using informatics in the system to help in the care of our critically ill patients in a project that's a collaboration between informatics and palliative care to understand which patients in our system might actually benefit from advanced palliative care. So this is, can you understand who might be at risk of dying in some period of time? Can you understand what people are going to go through, predictive over the course of some period of time? And we're actually utilizing this in a collaborative project funded through the Cambria Foundation, which funds a lot of work in palliative care, to try to improve the palliative care process within our healthcare system. Finally, this paper just came out, again in that same issue of Nature Medicine from Andrew and Mintu Tarakia, an electrophysiologist at Stanford. Again, many of you would say, well, I've used artificial intelligence in the EKG reading for many, many years, and it's really crappy. It doesn't work very well. And it doesn't in the systems that have been used thus far. But utilizing now a very different set of statistical tools, including the creation of deep neural networks, you can see that the machine can actually get quite good at reading the common abnormalities of electrocardiograms. An area that I think is ripe for disruption, utilizing artificial intelligence and large-scale data, is trying to understand. We go back to that picture I showed you earlier, the map of the United States, and the transition epidemiologically from heart disease as cause of death to cancer, but a very strong socioeconomic influence on what kind of death occurs in your zip code. And not surprisingly, the group at Facebook, Freddie Abanusi, is a Stanford faculty member and former Stanford cardiology fellow. He's actually an interventional cardiologist who's now the director of health for Facebook. And he's trying to understand, with the kind of data that Facebook has available to it, can they gain insights into the social determinants of health? And can that be useful as we think about things like public policy, behavioral change, et cetera? Certainly the technology companies have figured out in many ways better than we have in the medical profession how to change behaviors. Facebook is working with the American College of Cardiology. You see John Rumfeld's name here. They're working with Harlan Krumholz at Yale. They're working with us. They're working with the American Heart Association to try to see, can we use this kind of data to make some inroads in the social determinants of health and health inequities. Everybody know what this is now? A few years ago I put this up and almost nobody knew what it is. But people know what this is? How many of you have one? How many of you have more than one? All right, so we're getting there. That's the beauty of it, Neil. This is Alexa from, this is the Amazon Echo. I could have also put up a picture of the Google Home device. This is voice recognition, which is exquisitely sensitive that you can talk to. Built upon artificial intelligence to try to give you, picking up through voice recognition code words, to give you information. For those of you who think about things like CPR training, et cetera, if you go home and ask your Alexa, tell your Alexa that you've had a witness cardiac arrest, and can they teach you how to do CPR, and Alexa will walk you through the steps of bystander CPR. So there's some cool stuff that's very much health related. Now, what is the most mundane task that all clinicians want to get away from? Entering stuff into the EMR. So we have a project underway with our colleagues at DeepMind, the AI part of Google, that is called the AI Digital Scribe project. And Stephen Lin is one of our family medicine physicians who has been thinking a lot about this. He wrote a paper recently called Using Machine Learning to Build a Digital Scribe Artificial Intelligence that was in the Mayo Clinic proceeding. And we have embedded a team of Google engineers and Google Home devices, you can see it on the clinical wall, in 11 primary care clinics. And over the course of about 18 months, we're about 3-4 months into this, we're going to figure out if the machine can actually pick up through nuance, keywords, et cetera. Can the machine be taught not to just do transcription, but to actually write a note, and write a note in a way that clinical people would say, that's a good note. And we're starting with primary care because primary care, we think, has the broadest vocabulary. And so we think that we'll be able to gain some insights into the broadness of medical issues. Following that, we're going to go into oncology, cardiology, and do the deeper dive into the vocabulary to see, can we help with one of the leading causes of physician burnout and challenges, and that is the electronic health record. A couple more topics here. Eric Topol again, the patient will see you now. Patient empowerment. We all have phones, right? It's been called by the economists planet of the phones. Not only do we all have phones, in the US, 77% of us have smartphones. What does that mean? That means that we're going to be able to use digital technology to get better evidence. And there's a variety of things in clinical research that you might say, wow, I can use my phone to do fundraising. I could use my phone to do patient recruitment, patient follow-up, adverse event reporting, maybe even endpoint ascertainment. About 3.5 years ago, we launched a project with Apple called My Heart Counts, led by Ewan Ashley, Mike McConnell, Alan Young, which was really a way to collect data on cardiovascular symptoms and activity symptoms. Over the course of the first day that this was announced, we enrolled more than 20,000 subjects. And in the first report, we had 90,000 subjects download the app, and almost 60,000 subjects give us permission to collect their data. And we collect their data in an IRB-approved way through very simple screens. You can opt in, opt out at any time for different pieces of the data that we want to collect from you, and you can see how you can do that. And we reported this in JAMA Cardiology, just on roughly the first 50,000 subjects that gave us permission to use their data. For those of you who are interested in things like 6-minute walk test, if you, as an endpoint in clinical trials, in the entire literature, there's about 1,500, 2,000 patients that form the normative basis of the values for what is normal in 6-minute walk. Over the course of a very short time, we have over 10,000 subjects that have given us 6-minute walk data. So it's really extraordinary. We're now doing randomized trials through My Heart Counts. The first one we did this past year looks at different methods of delivering physical activity coaching. We're now beginning to try to understand, can we use not just the phone, but can we use wearable devices to begin to capture information? And the first project that you may have heard of is something called the Apple Heart Study, where we've done a large-scale study, population-based study, to identify, can you use the Apple Watch to identify atrial fibrillation. We enrolled over 400,000 subjects with this over the course of a couple of months. Apple sent out one email to a number of their users of the watch, and within about a week we had over 100,000 subjects sign up just based on that single email. There's nothing I've ever done in clinical research that has sort of that authority to it. But we identify whether or not, and remember what this is actually not identifying atrial fibrillation. This is identifying through an algorithm based on tachycardia and the irregularity of the tachycardia and the frequency of which it occurs. Utilizing machine learning, can it detect something that has a high probability of atrial fibrillation? And it actually looks pretty good that it can. And we'll be reporting these results later this spring to demonstrate to you, number one, what is the incident background in a population of 400,000 plus Americans of all different ages? What is the likelihood that they have atrial fibrillation in the background? And then the second part of the study is going to be, what do you do with that information once you get it? Facebook, sudden cardiac dissection. Spontaneous coronary artery dissection. Facebook page popped up because a group of people who had this condition realized that nobody actually knew a whole lot about spontaneous coronary artery dissection. So they formed their own research group, if you will. And this led to a collaboration with Mayo Clinic where, utilizing Facebook, they actually created a registry for participants who had had spontaneous coronary artery dissection. And just recently, when the American Heart Association released a scientific statement on spontaneous coronary artery dissection, they actually gave a shout out to the survivor-led initiative, which has sparked the collaboration research so far. This is patients driving the research agenda in ways that's never been done before. People are beginning to use Twitter as a way to collect information on cardiovascular disease and things that might be germane to the public health. There's an investigator from Penn who now has an R01 utilizing this sort of data for research. And I would say this, that it's all very well good about making discovery, saving life, but your research is making barely any impact on social media. Or this might happen to you when you go see patients. Our statistician will drop in and explain why you have nothing to worry about. So let me close with this. I think that in order to live in this world going forward, our young folks have a lot of opportunity. But in order to do that, they're going to have to get a different type of training, because this is the big job of the 21st century, to understand the convergence of biology and clinical medicine. Our biomedical engineering department created a new major called Biomedical Computation. We had a great conversation at dinner last night about things that you're doing, bringing together engineers and biologists. And we're very interested in this concept of how do you take people who are schooled in biology and school them in data science, and vice versa. That's really what the future is. You also have to start to think about how do you communicate, and not just communicate through the traditional peer review, but how do you communicate through social media? And Bobby Ye at Harvard is one of the best at doing what he calls tweetorials, where he will talk about a paper, a concept, completely using Twitter over the course of an afternoon. So in Silicon Valley, we think about this. I can't wait till technology replaces doctor. Medicine will be so much better. But we really don't believe that. What we really believe is there's this blending together of human intelligence and artificial intelligence. And we wrote this paper in JAMA last year that was a takeoff on very common Dr. Stead which he would make rounds with the frightened house staff, and he'd say, you know what this patient needs? This patient needs a doctor. And so we wrote a paper that what this computer needs is a doctor. And I think that where we're going to make the inroads is when we bring human intelligence, utilizing the tools, not to replace us, but to make our jobs better. So thank you very much for the opportunity to visit, and I've greatly enjoyed my time, and it's a terrific honor to be here.
Thank you so much for a wonderful presentation, and we have a little token of appreciation for you being the lecturer for the Bill Winters Lectureship. And it says, DeBakey Heart and Vascular Center expresses his appreciation to Robert Harrington, MD, MACC, for his outstanding delivery of the 26th Annual Bill Winters Lectureship. Thank you so much. Some questions. I think that was fascinating. Can you please use the microphone? Dr. Kleiman.
Yeah, so Bob, an outstanding lecture as always, no surprise there. Let's ask this. You had a slide that showed that the sexiest job of the 21st century is a data scientist. And, you know, sex is built into life as something to attract people. So how do you, no, it is really. But here's my question. How do you feed the machine? Now, imagine that everyone who goes into medicine and whom we trained becomes a data scientist. Where do we find the next Watson and Crick?
Yeah, so the corresponding, that was an article in the Harvard Business Review. The paper that I also have a slide of that I didn't put up was from the New York Times that said most of data science is janitorial work. And because a lot of data science is not so sexy. It's the cleaning of the data, and it's getting all the data amassed. And if you look at companies like Flatiron, a lot of their value has come in the curation of the data. So it's a lot of hard work behind the scenes. I don't think at all, Neil, that we're going to we're not going to turn the entire ship away from basic biology investigation. But I do think two things, one of which to practice medicine in the years going forward, you're going to have a deeper understanding of the data sciences than most physicians currently have. Number two, whether you're doing bench science, or clinical medicine, you're going to need to have a foundation of data science. And then number three, there's going to be a special place for people who do have a very high training and background in computational methods with an understanding of clinical medicine. So I think it's going to be part of the equation. It's not going to be all of the equation. I'm going to guess, John, that your world has changed dramatically in terms of the computational requirements.
I'll comment on that, but I think Deepan Shah has
Okay.
a different question.
Yeah, just a quick question. I mean, I think this is phenomenal, and I think really gives us kind of an insight into what we're going to see the transformation in medicine in the next few years. The one question I've got is how do we balance that, the benefits here, against the concerns of patient privacy and data breaches that we hear about every day? What steps do you think are being taken to safeguard this very valuable and private information?
Yeah, I think that's one of the key questions. It's why I put up that slide about Google, Facebook. There's no question with data breaches, et cetera. This is a serious issue that from a societal perspective has to be talked about. I think you are going to see more regulation of some of the technologies and some of the tech companies because of that concern. But I would also say that I think that we're going to also enter an era where we have to rethink what I'll call past views of data and of research. And I'll give you one example. If in the aspirin study, if 45% of people are taking one dose, 45% of people are taking the other dose, and there's really no rhyme or reason why they're doing it, should we have to get informed consent to randomize them? And I argued that we shouldn't, that actually we're doing things not so systematically anyways. Why not randomize people and actually learn the outcome of a really important public health question? I think we're going to have a whole debate, for example, about the ethics of informed consent. Does informed consent slow down the research process in a way that's not helpful? So stay tuned. I think there's going to be a lot of debate on this.
Bob, that was spectacular. Thank you for that overview, and I think Stanford made the right choice 7 years ago when they had you join as chair of medicine. I have, there's a model that you have suggested that biocomputational engineers will be trained in medicine, or the medical docs will be trained in biocomputation. There is another approach, and that is to embed the bioinformatics folks with medical docs or with the biologists, and well, I'll show you today. That's the tack that we've taken. I think you, as a biologist, you need to know enough to work with the bioinformaticians, but that area is getting so specialized now. The algorithms that are required, the innovation that's required to stay at the cutting edge is so specialized. I'm not sure that a one person can do both successfully, so maybe you could comment on that.
Yeah, I fully agree with that comment, and I think there are a lot of different models. I think that there will be a small number of people who acquire both set of skills. I think it'll be a very small number. I think the majority will be depending upon collaboration and trying to understand the language. You know, I'm not trained in biostatistics. I've learned it on the job, so to speak, but I can carry on a conversation at a fairly high level with my statistical colleagues, but I'm not doing my own analyses. Yeah. And so I see a lot of that. We are also doing, as you know, one of the groups that we've really built within the Department of Medicine during my time, one of the biggest investments we've made is in informatics. And we've grown, we had 1 or 2 singular informatics people in the department. Now we have over 20 that are embedded into the department for the reason that you suggested, is to get them collaborating with the clinicians. I do think we have to do a better job in medical school curricula about teaching of computational methods, where I think at least most schools don't do it very well.
Can you talk a little bit more about the intersection of precision medicine, individualized care plans, and population health?
Yeah, I think that oftentimes pop health and precision health are presented as dichotomous entities. You can't do precision without having population level data. And so we're actually trying to make sure that the green button approach is an example. We've accumulated, you know, tens of millions, hundreds of millions of records to be able to get insights into questions that we can apply in a personalized way. So I see that you cannot do precision health without population level data. I also think that you can talk about precision population health. And if you look at that transition from heart disease to cancer map, that's precision at the zip code level. Right. And if you get into the details of that, it's you know, you can have neighborhoods next to each other where one neighborhood's dying of cancer, one neighborhood's dying of heart disease, and why is that? It's the socioeconomic divide. And so I think then we can begin to have conversations as a society around policy choices based on data. So I think we're going to be seeing both play out in the next few years, and I'm most excited. I'm very excited about the policy issues right now.
Well, Bob, with that, thank you very much for a wonderful presentation, and thank you for being the Bill Winters lecturer. Appreciate it. Thank you very much.
Thank you for having me.
Oh, that was great.
Hello, my name is Alan Lumsden. I'm the chairman of the Department of Cardiovascular Surgery here at Houston Methodist Hospital.
And I'm Zvonimir Krazier, current president of the International Society of Endovascular Specialists. We are excited to invite you to join us for our first annual Evs Symposium. This premier conference will take place at the Houston Methodist Research Institute in the Texas Medical Center.
This is a 2.5-day conference, and it will offer didactic lectures from well-renowned cardiovascular interventionalists. It will also feature intensive hands-on workshops designed to teach interventionalists a variety of techniques. We plan to offer 3 tracks, one for the novice, or the new young surgeon or young interventionalist, an intermediate track, and an advanced track. That means you can hone your skills at an individualized level. By the end of the conference, attendees should be ready to apply these techniques and improve their clinical practice.
We hope you will join us, and we look forward to seeing you in September.
Hello, my name is Alan Lumsden. I'm the chairman of the Department of Cardiovascular Surgery here at Houston Methodist Hospital.
And I'm Zvonimir Krejzer, current president of the International Society of Endovascular Specialists. We are excited to invite you to join us for our first annual Evs Symposium. This premier conference will take place at the Houston Methodist Research Institute in the Texas Medical Center.
This is a 2.5-day conference, and it will offer didactic lectures from well-renowned cardiovascular interventionalists. It will also feature intensive hands-on workshops designed to teach interventionalists a variety of techniques. We plan to offer 3 tracks, one for the novice, or the new young surgeon or young interventionalist, an intermediate track, and an advanced track. That means you can hone your skills at an individualized level. By the end of the conference, attendees should be ready to apply these techniques and improve their clinical practice.
We hope you will join us, and we look forward to seeing you in September.